Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and welcome to the first of many lectures inshallah in this new series by the Ophthalmology Scholars Society at King Saud University. Now, before we begin, I'd like to point out that we have previously made a few lectures and they're uploaded in the YouTube channel, and I do recommend you check them out because I believe you will find them beneficial. So we begin with acquired eyelash disorders, acquired eyelid disorders. So, just a quick disclaimer, ophthalmology is a very broad specialty, as I came to realize while preparing the material for this lecture. And the idea of covering acquired eyelid disorders in a few minutes is quite ridiculous, to be honest. So we will focus on the important pathologies, and we won't go into the details of surgical technique and the details of management to keep things simple. And at the end, there will be a quiz. You can find the link to in the description. So just an introduction to the course. Like I said, this is a new course. It is supposed to be aimed at medical students or undergrads and interns who are interested in ophthalmology. And we hope to make this a review course that would spark your interest in ophthalmology even more. These are the pathologies we will discuss. We'll go through Chalazion, Blepharitis, Stye, Trichiasis, and some miscellaneous eyelash disorders. Okay, a basic review of anatomy. Now, the outermost layer is the skin. And within the skin, we have the regular sweat glands or eccrine glands that are present throughout the body. This layer of skin is actually thought to be the thinnest layer of skin in the whole body. Beneath it, we have a layer of subcutaneous tissue, and then we have the orbicularis oculi muscle, which is supplied by the 7th cranial nerve. An important note is that the muscle responsible for closing the eye is the orbicularis oculi, supplied by the facial nerve or the 7th cranial nerve, while the muscle responsible for opening the eye is the levator palpebrae muscle, supplied by the 3rd cranial nerve or the oculomotor nerve. Now you can imagine in Bell's palsy, for example, or 7th cranial nerve palsy, facial palsy, the patients have trouble with closing their eyes because their orbicularis oculi muscle is no longer functional. This would result in eyes being constantly open and drying out, and this results in damage to the cornea. While consider a patient who has a 3rd cranial nerve palsy due to a stroke, for example. This patient would have trouble with elevating his eyelid because his levator palpebrae muscle is no longer functional. This would result in drooping of the eyelid or ptosis. So this is an important point that I'd like you to keep in mind for upcoming lectures. Now, moving on, at the skin, we were at the skin, yes. When you go further down the skin, you reach the eyelid margin. This is where the cilia exit or the eyelashes exit. And closely related to the eyelashes are two specialized sebaceous glands, the glands of Zeiss and the glands of Moll. They're both closely related to the eyelash, like I said, and they function in lubricating the hair follicle or the eyelash follicle and keeping it nourished. So behind this layer of skin and the orbicularis muscle, we have the tarsal plate or the tarsum. This is what gives the eyelids their structure, we can say. It's a dense fibrous tissue that is lined in the inside by meibomian glands. These meibomian glands secrete meibum, which is an oily substance, and it is the outermost layer of the tear film. This oil keeps the tears from evaporating, as my colleague Lujain will discuss in her lecture on lacrimal disorders. The meibomian secretions, they keep the tear film from evaporating and thus your eyes from drying out. And we'll discuss pathologies pathologies that damage the meibomian glands will result in dry eyes. A final point in anatomy: the inner part of the eyelid, or the posterior margin, is lined by conjunctiva, as you can see here, and the conjunctiva reflects upwards at the fornix and then goes back downwards. Same thing over here. This conjunctiva then inserts into the sclera, which is not illustrated here, but you can imagine. Now, a patient or someone who wears contact lenses, if this reflection wasn't there, you can imagine that their contacts can actually get lodged behind their eyes, which I'm sure you can imagine is not very nice. So that's about it for anatomy. Moving on. So, eyelid inflammation. We begin with chronic marginal blepharitis, or simply blepharitis. Blephar, meaning eyelid, and itis means inflammation. It's a chronic condition. It's a very common cause of eye discomfort and irritation, and it affects people of all ages. It's rarely sight-threatening. Although the problem with it is that it is difficult to manage. That's because the etiology or the disease process is not well understood, and the signs don't seem to correlate well with the symptoms. There are two types of blepharitis. We have anterior and posterior blepharitis. There is some degree of overlap between the two in that they both have similar presentation. They can both cause itching, red eyes, foreign body sensation, or sand in the eyes, as patients describe. They can have burning, tearing, erythema of the eyelids, and crusting and stickiness around the eyelashes, as you can see in the picture, especially in the mornings. So, moving on to anterior blepharitis. Here, the inflammation is situated anteriorly. It's more concentrated at the eyelashes. And you can see the squamous debris that forms at the eyelashes. This type is most commonly associated with Staphylococcus aureus infection of the eyelashes. It's also associated with seborrheic dermatitis, atopic dermatitis, and contact dermatitis. In contact dermatitis or allergic contact blepharitis, this is a delayed type 4 hypersensitivity reaction, unlike eczema, which is type 1. So the symptoms would appear 24 hours to 72 hours after the exposure to an allergen. The allergen could be, or most commonly is, ophthalmic medication. It can be cosmetic products like expired makeup products. And the treatment in this case would be simple. Unlike other causes of blepharitis, the treatment would simply be to avoid the allergen. Now, staphylococcal blepharitis characteristically is prevalent among younger age groups, and on examination you would see hard deposits or crusts surrounding the eyelashes. These are referred to as collarettes, and characteristically, removal of these crusts would cause ulceration and bleeding. Now, a last point, another cause of anterior blepharitis and posterior blepharitis actually is the Demodex mite. This is considered when a patient comes with prolonged and refractory blepharitis that's not responding to anything. We consider the Demodex mite and looking for it on slit lamp or by epilating the eyelash and looking under the microscope to look for the Demodex mite. and treatment would be different than anterior blepharitis caused by Staphylococcus aureus in this case. As for posterior blepharitis, aka meibomian gland dysfunction, here the inflammation is mostly in the meibomian glands, which, if you remember from anatomy, are situated in the tarsal plate. Now, the pathology is that for some reason, for some not clearly understood reason, the meibomian glands are dysfunctional, whether it be from advanced age, contact lens wear, hyperkeratinization. All of these are mentioned in the literature, although no clear cause is clearly identified. Regardless, the meibomian glands are dysfunctional, and when they're dysfunctional, this leads to stasis and obstruction. And as the rule goes in pathology, stasis leads to inflammation. So this inflammation will lead to progressive destruction of the meibomian glands. And as we mentioned, the meibomian glands are responsible for the outermost layer of the tear film, which is the oily layer that keeps the tears from evaporating. So in this case, one would have evaporative dry eyes, as the tears are evaporating easily. Now, just one point, in contrast to staphylococcal blepharitis, which causes anterior blepharitis, meibomian gland dysfunction is prevalent with increasing age, unlike staphylococcal blepharitis, which is more common in younger age groups. So this is a point to keep in mind. And a special association with posterior blepharitis is rosacea. Rosacea seems to be more prevalent, or those with rosacea seem to have posterior blepharitis more than the general population. And as we said, another association is contact lens wear. This is possibly due to the chronic irritation of the meibomian glands, which is caused by the prolonged use of contacts. Now, as for the complications, in both anterior and posterior blepharitis, the inflammation can progress and reach the cornea or reach the conjunctiva, causing blepharoconjunctivitis. Blepharoconjunctivitis, like I said, can also progress to the cornea, blepharokeratoconjunctivitis. And this would cause ulceration in the cornea, which would be sight-threatening in this case. Like we mentioned, blepharitis is rarely sight-threatening. When would it be sight-threatening? When it causes blepharoconjunctivitis. Blepharokeratoconjunctivitis, although this is not very common. Now, it is thought that the mechanism of the corneal irritation is that patients that have itching, as we mentioned, both anterior and posterior blepharitis would have itchy, tired eyes. So as the patient itches and rubs their eyes, this leads to release of the inflammatory mediators into the tear film, and then it reaches the cornea and the conjunctiva, like we mentioned. Now, meibomian gland dysfunction or posterior blepharitis can also be complicated by chalazion or chalazion and internal hordeolums. These are two inflammatory lesions that are characterized by swelling. We will discuss them further in the upcoming slides. As for the treatment of blepharitis, the goal of treatment is mainly symptomatic management, because unfortunately there is no established cure for blepharitis. So the cornerstone of treatment for both anterior and posterior blepharitis is daily eyelid hygiene, at least twice a day. What do we mean by eyelid hygiene? Eyelid hygiene basically means warm compresses for 5 to 10 minutes. This serves to soften the crusts, which then can be removed by cotton buds that are dipped in dilute baby shampoo. Or there are many commercial eyelid and eyelash scrub kits that are available over the counter. that do the same job. Now, in acute cases or acute exacerbations, topical steroids can be used, or even topical antibiotics in the case of staphylococcal blepharitis, or even topical calcineurin inhibitors. However, we don't like to stay long on topical steroids because the side effect profile is terrible, and side effects can be serious, including that includes a raised intraocular pressure, glaucoma, subcapsular cataracts, herpes simplex reactivation, and skin atrophy. So these are the side effects of chronic steroid use, but thankfully this is limited to chronic use, like I said. Short courses during acute exacerbations do not usually result in these symptoms. Now, moving on to eyelid lumps, we'll speak about Chalazion, hordeolums, and Molluscum contagiosum. Okay, starting with Chalazion, also known as a meibomian cyst. This is basically an inflamed and swollen meibomian gland. Or to be more scientific, it is a chronic lipogranulomatous inflammation of the meibomian gland or the gland of Zeiss caused by retained secretions. This is the most common lid lump. Now, what makes it a granuloma? Because like I said, it's a chronic granulomatous or lipogranulomatous inflammation. The Chalazion is considered a granuloma because under histopathology, you would see macrophages full of lipids or lipid-laden epithelioid cells, which are basically macrophages. And you would also see multinucleated giant cells and lymphocytes, which is the definition of a granuloma. Now, a key feature of Chalazion is that it is a painless nodule. And mostly it involves the upper lid because the upper eyelid has more meibomian glands. And it's usually away from the lid margin, unlike styes, which we will come to discuss, which are usually at the lid margin. So, as for the causes of Chalazion, one of them is posterior blepharitis, as we mentioned, where the meibomian glands are dysfunctional and inflamed. These can progress to an inflamed Chalazion. Now, it's not uncommon to see patients with both blepharitis and Chalazion, and that's the reason why. In terms of complications, well, the first, I'm sure you can see from the picture, it's cosmetically problematic, especially if it's this large. Another complication is that Chalazions can get infected and form an acute abscess, which would be called an internal hordeolum. This is in contrast to an external hordeolum, which is basically another name for a stye. Now, another complication is mechanical ptosis. This is due to the extra weight being put on the eyelid. And also it can cause blurry vision. If the Chalazion presses on the cornea and causes a dent on the surface, it can lead to astigmatism, therefore blurry vision. Now, although very, very low, there is a risk of malignant transformation in Chalazion. As for the management of Chalazion, this depends on the size of the lesion and how much trouble it's causing and its location. So 1/3 of Chalazions will resolve on their own. So observation is an option if the lesion is small and not causing that much trouble. And in that case, hot compresses might speed up the resolution because they're thought to enhance the flow of secretions in the meibomian glands. Of course, if it's acutely infected, oral antibiotics can be used, and expression of contents may be appropriate if it's near the lid margin manually. Steroid injections are commonly used, intralesional steroid injections. and they have a pretty good success rate. If that fails, we can move on to surgery or incision and curettage from the conjunctival side, from the posterior margin of the eyelid, under local anesthesia. And this management, Chalazion surgery, is contraindicated if the chalazion is acutely infected or if an internal hordeolum develops. So moving on to Chalazion surgery, this is the equipment used. We have the Chalazion clamp, and this is the Chalazion scoop. The idea is we use the clamp to squeeze the chalazion so that when we make a vertical incision, the contents of the or the retained contents of the gland are expressed out, and then we use the Chalazion scoop to further empty the retained material. And then we don't need to suture it, we just compress and stop the bleeding, and then we could consider sending the material for histopathology if we suspect a tumor in cases of recurrent chalazion or unresolving chalazion, because one tumor, which is sebaceous gland carcinoma, is known to present as a chalazion-like lesion. So it should be considered in this case. Moving on to external hordeolum, commonly known as Stye. This is an acute abscess of the eyelash follicle and its associated gland of Zeiss, usually due to staph infection. This is common in children and young adults, and it can be very tender. I'm sure you can notice from the picture the difference in the location and the shape between this and the chalazion. Here the inflammation seems to be at the lid margin and closely related to the eyelash follicle, and it's pointing outwards. It's like a pimple that's pointing outwards. This is in contrast to the chalazion. The risk factors seem to be related to poor hygiene. They include contact lens wear, using contaminated eye makeup, blepharitis, which is also related to poor hygiene, and the treatment of which is actually lid hygiene, as we mentioned. As for the treatment of Stye, once the Stye develops, topical or oral antibiotics are used to treat the infection. Hot compresses can help, so can epilation of the eyelash, and the complications can be quite serious. This Stye can progress to preseptal cellulitis, and preseptal cellulitis might progress to orbital cellulitis, which is a true ophthalmic emergency. So if patients progress to preseptal cellulitis, systemic antibiotics are warranted. And also close follow-ups and close monitoring of progression to orbital cellulitis is needed. As for internal hordeolums, as we mentioned, this is an acute abscess of the meibomian glands, not of the glands of Zeiss, as in this case. And it is a complication of chalazions, like we previously mentioned. So moving on to Molluscum contagiosum. This is a highly contagious viral infection of the skin. The lesions spread by autoinoculation from itching or direct contact with infected individuals, or even indirect contact from contaminated objects maybe. They can be single or multiple, and the lesions are generally not painful. However, pruritus or itching is common. Lesions typically manifest 7 weeks after infection, and you can see the lesions. They're characterized by being umbilicated and dome-shaped. This is perhaps the most distinctive description. Not many other lesions are umbilicated. So, lesions are usually near the lid margin, and there might be viral shedding into the tear film, which leads to chronic follicular conjunctivitis. And this is an important complication. If the lesions are multiple and widespread and large, we should think of immunodeficiency, like HIV or leukemia or other causes of immunodeficiency. The management is mainly prevention. How? With strict hygiene, hand washing, avoid scratching lesions, avoid sharing garments and towels, and limit contact with infected individuals whenever necessary. Lesions can resolve on their own, but this would take months to years. So, usually, we use topical management or cryotherapy or surgery. Surgery in the form of excision and curettage. One point about topical therapy is that it hasn't shown much efficacy, with the exception of one drug called imiquimod. Now, cryotherapy is excellent in terms of outcome. However, it must be performed with caution if the lesion is close to the eyelashes, because it might cause depigmentation of the eyelashes or even loss of the eyelashes. Finally, disorders of the eyelashes. So we will focus mainly on trichiasis, and then we'll give an overview of other miscellaneous eyelash disorders. Trichiasis is a common condition in which the eyelash or eyelashes are misdirected inwardly towards the globe, leading to corneal irritation or abrasion. It can be caused by a scarring process, in which case it would be called cicatricial trichiasis. Cicatricial just means relating to scarring. So a cause of cicatricial trichiasis is trachoma. Trachoma is caused by infection by Chlamydia trachomatis, which results in a scar in the eyelids that leads to the misdirected eyelashes. Another cause of trichiasis is chronic blepharitis or even surgery. It can also be caused by an entropion, where the eyelids will be inverted as well. So you would have inverted eyelids leading to inverted eyelashes in entropion, in contrast to other causes where it's only the eyelashes that are inverted. Now, the management is temporarily with epilation of the eyelashes, although recurrence is the rule with epilation, and it's only temporary. The definitive management is with cryotherapy or electrolysis. We close with some miscellaneous eyelash disorders. We have distichiasis, which is an abnormal second row of eyelashes originating from the meibomian gland openings. This can be congenital or acquired, secondary to chronic inflammatory conditions. We also have trichomegaly, which is an excessive growth of eyelashes. This can be secondary to drug use, like prostaglandin analogs. And madarosis refers to loss of eyelashes. This can be due to also chronic inflammation or even chemotherapy. Finally, poliosis, which is a premature localized whitening of the eyelashes or eyebrows. It can be due to VKH or Vogt-Koyanagi-Harada syndrome, and it can be due to vitiligo and many other conditions. With that, we conclude. These are the references, and thank you very much for your listening and your attention, and be sure to reach out and follow us on all these social media platforms. Thank you very much.